Okay, so when in the EMS time period that we have with our patients are we thinking any kind of cardiac compromise? Well, these are some very common signs and symptoms that you guys are going to see, which will hopefully kind of start leading you towards the cardiac realm of disease processes. Obviously, any kind of chest pain or discomfort. The big one there is the feeling of impending doom. Haven't really talked about the feeling of impending doom a lot, but it really does happen to some of our cardiac patients. And what I mean by the feeling of impending doom is like your patient might say, "Man, I just feel like dying right now." Right? Be careful. They might just do that. That is what's called the feeling of impending doom. That means that your patient is starting to give up. Okay? It's almost like a self-fulfilled prophecy, right? Where they're having this huge ass heart attack and you guys can see it a mile away once you guys get some experience. And your medic's telling you, hey, we got to hustle to the hospital. And this guy says, man, I just don't think I want to live anymore, or I don't feel good enough to even carry on, or anything along those lines. Be careful because he might just die on you, okay? Anxiety, irritability, all right? We are not perfusing something, guys. The first thing to go is mentation, okay? The other big thing, radiating pain. Okay, pain that doesn't stay in one spot. And the big ones are moving up your jaw, moving down the arms, shooting through the back, or possibly going down to the abdominal or epigastric regions. Dyspnea, again, is just shortness of breath. A sudden onset of sweating. Okay, now this isn't a sudden onset of sweating after running 3 miles. This is a sudden onset of profuse sweating while sitting there watching The Price is Right or something like that. Okay, abnormal pulses at any location. Okay, or an abnormal blood pressure that might be abnormal for the patient. Again, that's something that you guys are going to have to do a little digging on. Okay, you guys are going to have to start doing a history. Okay, finding out the history of the present illness and trying to find out about the patient's medical history in general. And anytime possible, nausea and or vomiting. Okay, when the body starts to get distressed, it wants to evacuate everything. Okay, so nausea, vomiting. They could be incontinent to bladder or bowel as well. They might have peed themselves. They might have pooped themselves. Okay, it's the body's way of evacuating everything and basically preparing for death. Okay, so going into your cardiac assessment, time is muscle. Okay, time is muscle. We need to go. Let's not wait. Let's go. Okay, always consider your scene survey. Always get your PPE on. Make sure that you guys are constantly always asking for additional resources. Okay, you can always cancel us. All right, but let's at least get us rolling to the call with you if you are not already with a medic. Okay, you guys are going to learn once you guys get into your services about continuous EKG placements or continuous how to put on the actual 12 lead EKG. And you guys aren't able to interpret it, but you guys are able to put those on there and hit print, right? Hit print on that thing to see if we are getting any changes on the monitor. And that way we can either give it to a medic, so that when you guys were first on scene, hey, this is what we had when we first on scene. I've given you guys about 4 or 5 different looks at the heart. That's really going to help your medic out, guys, okay? Cardiac medications, what are they? What do you guys carry that are cardiac medications? Well, you got oxygen. You can put the patient on oxygen. Absolutely. You can give them aspirin. Okay? And you can give them nitroglycerin. All right? Just remember all the parameters that have to be in place for nitroglycerin. Make sure you're giving them the right dose. Make sure you're calling the doc before you do it. Please, please, please make sure you go over nitroglycerin before this next exam. Okay? Please make sure you're going over nitroglycerin before this next exam. I don't think we're going to have the drug quiz on nitroglycerin before this exam comes up. So make sure that you guys know everything you need to know about nitroglycerin for this exam coming up. Okay? Okay, so we got our scene safety, we got ALS rolling to our call, and we got all of our PPE on. It's time to make patient contact. When we're doing our initial assessment, what is your general impression of this patient? Is this patient sick? Is this patient not sick? Period. Based on that, you're going to make a priority status. Am I going to stay and play? Am I going to load this patient up in the back of the ambulance and do everything en route to the hospital? Hopefully, On most of the patients you guys are going to be dealing with, specifically when we get to scenarios in this class, you guys are going to load and go. You guys will not stay in play, okay? You're going to do high flow oxygen, hopefully through a non-rebreather, okay? We want to try to make the patient as comfortable as possible. We want to try to make sure that we are recruiting as many red blood cells as we can in order to perfuse the areas that we are able to perfuse, okay? There's been a lot of research on oxygen saturations, specifically with heart attack patients, okay? Our target O2 sat is at 94%. And it's almost to the point where even if we are right around 94%, we want to just titrate the oxygen to it. So if you guys put this patient on a non-rebreather and they're already at 94%, okay, we can actually be causing more damage to their hearts by giving them too much oxygen. So if you guys are right at that 94%, kick down the oxygen a little bit, okay, maybe not necessarily at 15 liters per minute, but let's drop it down to 10 and see what happens, okay? If they're still maintaining, let's take them off the non-rebreather and maybe just put them on a couple of liters per minute via nasal cannula to keep them at that 94% oxygen saturation. And really, guys, if it comes down to it and they're at 94%, they don't need oxygen, then don't give them oxygen, okay? Let them do their thing, but keep an eye on it just in case they start to drop. We want to really try to keep that oxygen saturation at 94%. There is a ton of literature on this right now that you guys are more than welcome to check out. You guys will definitely get some of that literature once you guys get into paramedic school. Allow the patient to assume a position of comfort, okay? We don't want the patient exerting themselves. This is not the patient that you're going to walk to your gurney. This is the patient where you're going to take your gurney to the patient and you're going to help them stand and pivot, or possibly even pick them up yourselves and put them on the gurney. They can't exert themselves, okay? Once we have stabilized the ABCs, we're going to start doing a history. Now, I'm going to say this specifically for cardiac patients, okay? You have no business whatsoever doing a patient history and physical examination on scene if you have already confirmed that this is a heart attack. I'm going to say that again. You have no business wasting the time to do a history and a physical examination on scene if you have already confirmed that this is a heart attack. Okay? Get your ABCs done. We know the ABCs are good. It's time to load and go. All right? We could do all the history taking we want all the way to the ride to the hospital. When we're doing a history, we want to do an OP-QRS-TU. Okay? We want to make sure that we're doing our sample. We want to do a baseline set of vital signs for sure and recheck often. Okay? And if you guys are by yourselves, let's at least do a 12-lead EKG. Again, you guys are going to have no clue what this stuff means, all right? But you guys have the ability to transmit these to the hospital. Pretty much every service nationwide has the ability to do that now. Or you can hand that off to your paramedic partner or your paramedic rendezvous and say, hey, look, this is what we first had. This is the first patient contact. Here is your 12-lead EKG. Guys, that helps us out a lot. That tells us a lot of stuff on what's going on with this patient. Because as soon as we get in the back with you, if we're rendezvousing with you, or if I'm working with you guys as a partner, as a paramedic, and you guys get that 12-lead EKG, I'm doing serial 12 leads. Right? Every 5 minutes, I'm hitting that 12-lead button. Take a look to see if I have any changes that I can't see on my patient, but I can see on the monitor. Okay, some other things to think about. We've already talked about oxygen. We want to titrate to that 94% oxygen saturation, okay? Let's think about aspirin. Now, technically, aspirin is an anticoagulant. However, we as EMT basics here in the state, we use it for its antiplatelet aggregate properties. So if you guys get a question on what is the classification of aspirin, I want antiplatelet aggregate. Okay, again, this does not take away the clot. What it does is it makes the platelets slippery so that the platelets can't stick together. So the clot's still there, it's just not going to get bigger. Okay, this will help increase perfusion distal to that clot. Okay, and make sure that we're doing our Dr. Pats. We got our right drug, we got the right route, we got the right patient, we got the right amount, we got the right time that we gave it, and we're going to scribe it all down. We're going to write it all down. Okay. What is your dose? I would look that up. Okay, so we got the patient on some oxygen. We're titrating that oxygen to 94% on the SpO2. We've given this patient 324 milligrams of aspirin, or matched what they have already taken, up to 324 milligrams of aspirin. And now we got to think about nitroglycerin. Okay, so nitroglycerin, you guys have a ton of parameters here in the state in order for you guys to give it. Okay, first of all, it has to be prescribed to the patient. You cannot give nitroglycerin unless they already have a prescription for the patient. You also need to have an MSEP. They must be online. MSEP, you have to tell them patient demographics. They want their age, they want their sex, they want their chief complaints. They're going to want your first set of vital signs, and they're going to want to know why you believe this patient is having a heart attack. Okay, so when you contact the MSEP, you better have your OPQRST done. You better have your sample done. You better have your vital signs down. Okay, and make sure that those vital signs are within your parameters. Okay, specifically for nitro. All right, you're going to do Dr. Pat's. And remember, we have to ask about SPED use for both males and females. SPED stands for sexual performance enhancing drugs. Your Viagras, your Cialis, stuff like that. Pretty sure I already told you the story about Viagra. But if you hadn't, remember that Viagra was actually created for women, postmenopausal women. And it was created to keep them moist in order for them to continue to have sexual relations, okay, with their partners, right? And then I think it was like Ohio State, or I don't know, one of those schools back east or whatnot. Some of these frat guys took it to a party, and they took it, and all of a sudden found out that they had these raging hard-ons, right? And realized that, hey, this can benefit men, right, for that have erectile dysfunction, and basically became multi-billionaires overnight. Okay, from sitting there and smoking pot and drinking and just happen to pop some pills, right? They happen to be Viagra, and running around with these raging hard-ons all night, and they made a lot of money on it. So good for them, right? Make sure you guys are looking back over your nitro. Make sure you guys go back to your pharmacology. I'm not going to spend any more time on it. Make sure you guys go back over your dosages for nitro. Okay, so real quick, we have sprays, we have pills. Okay, either way, you're looking right at about 0.4 milligrams, whether it's the spray or the pill. You have a max dose of 1.2 milligrams, so you can give up to 3 doses anywhere between 3 to 5 minutes apart. Before you do another dose, you have got to make sure that you assess the patient before and after each dose at the EMT basic level, that their systolic blood pressure is greater than 100. Okay, their heart rate, which isn't on this slide, guys, their heart rate has to be above 50. So the systolic above 100, heart rate above 50. Patient has been prescribed nitro already. You guys believe they're having a cardiac event. You guys have talked to the MSEP. The patient has stated that they have not taken any SPEDs within the last 48 hours, and you have a heart rate above 50 and a systolic blood pressure above 100, you can give nitro. Okay, guys, I skipped over some slides, pretty much the skills videos for if it's a pill or a spray. We have those in your lab shelf for you guys to watch. So what is nitroglycerin? Nitroglycerin is a potent vasodilator. It actually decreases the cardiac workload, okay? And because of this, it actually reduces the afterload. So because we're reducing afterload, that's because that's how we are actually dropping the blood pressures on these patients, okay? It can very well relieve the chest pain of the patient. That's why we want to do an OPQRSTU, specifically the severity scale between 1 and 10, before we give the nitroglycerin, okay? And then before we give another shot of nitroglycerin, we want to see if that patient's still in pain, see if that if that number went down or if that number went up, whatever it happens to be, okay? We want to try to get, specifically with heart attack patients, with acute myocardial infarction patients, we want to try to get their patient down to a 0 as best as possible, okay? Hypotension can occur, okay? So we need to make sure that our heart rate is above 50, and we need to make sure that our systolic blood pressure is above 100 at all times, and make sure you are continuously reassessing your patient, specifically if you are giving nitro. Here's all the contraindications for you guys at the EMT basic level here in town. Okay. Again, their heart rate has to be above 100 systolic. They can't have a head injury. They can have not used any kind of SPEDs within the last 48 hours. We do not give this to infants or children, or the patient has already met the maximum dose before we got there. And you guys have confirmed that the medication that the patient is taking has not expired. If they have taken an expired medication, they have not taken their nitro. I'm going to say that again. Okay? If you get on scene and the patient already says, hey, I already took 3 nitroglycerin tablets, and you look at that container and it is expired, they did not take their nitro. Give them your own. Okay? If the patient does not have a prescription, if they have not already been prescribed nitroglycerin, you guys cannot give nitro. Even with a doctor online, you cannot give nitro. Okay? And you need to make sure that you have the doc online explaining all of this to him or her in order to get authorization, in order for you to be able to administer the nitroglycerin in the first place. If the doc says no, you're not giving the nitro. Again, do not stick around on scene. Okay? Time is muscle. All right? We need to get them to the appropriate facilities. We need to get them to what's called a PCI capable facilities, or what's known as the cath lab, right? In order for them to perform a cath, in order to open that vessel up for our patient. Okay? Let's get them to the people that make the big bucks. Okay? The true heroes. And let's make sure that we get them there in a safe, calm, timely manner. Okay? Do not walk them to the ambulance. You take your gurney. Don't be a lazy ass. Okay? Don't be a lazy EMT. Get the gurney out of the back of the damn ambulance. Take it to them as close as you can get it to the patient safely, and help the patient to the gurney. We do not want the patient exerting themselves. Okay? Mode of transport is basically going to be up to your paramedic. Okay? However, just know that those lights and sirens can increase the patient's anxiety, and that's something that through therapeutic communication, hopefully we'll be able to conquer. Okay? And if you're by yourself, let's try to intercept with ALS if possible. Again, if we're closer to the hospital, let's just give the hospital a heads up and get them there. Okay? And then we need to prepare the automatic external defibrillator. And this is something that you guys are going to have a talk with the patient, because you're going to have to take off their shirt. You're going to have to apply the pads onto their chest. And I'm sorry, I don't care how good you are at therapeutic communication. Every single person knows what the hell those pads are for. Okay? And you tell them, look, sir, I told you guys before, don't ever bullshit your patients. Don't ever bullshit. Don't ever tell your patients it's going to be all right. You do not know. Do not give them false hope. Okay? Yeah, bro, you're having a heart attack. Straight up. Okay? I'll show them on the monitor. I'll try to give them a crash course real quick in 30 seconds. Hey, man, you see this on the monitor? You see this on this little piece of paper? This is where your heart attack is happening. I need you to relax. I need you to trust me. Okay? I'm going to put these pads on your chest. I'm not going to do anything with them unless you go unresponsive. That's how you have that conversation. Okay? You do not bullshit your patients. All right? Don't be that EMS provider. Oh, sir, everything's going to be okay, right? When it's not. When he's got tombstones on the EKG, okay? That doesn't mean that everything's going to be okay. Do not bullshit your patients, all right?